Hello, everyone. Welcome to Global Pandemic Response, What's Next? The USHCA webinar series, The Way Forward. Today's event sponsor is Guardians of the Angeles Charitable Foundation, based out of Los Angeles. We are recognizing this organization because they made a significant contribution to the state of New Orleans, especially city, to the state of Louisiana, especially city of New Orleans during the pandemic. And we have today with us great panel, and let me go through the introduction very quickly. First with us is Dr. Molly Coyle. She's an executive in residence at AVIA, a network of large health delivery system seeking to advance care delivery transformation through the identification and deployment of effective digital solutions. She has held many leadership roles, such as Chief Innovation Officer for UCLA Health and Head of Institute for Innovation at UCLA. She was also the founder and CEO of the Health Technology Center, the premier forecasting organization for emerging technology in healthcare. She also served as Commissioner of Health for the state of New Jersey, Director of the California Department of Health Services, and Head of Division of Public Health Practice at the Johns Hopkins School of Hygiene. She is an elected member of the National Academy of Medicine. She's a member of many, many boards, which I will save up time and invite you to check out the link where you can read the extensive bio. Next, we have Dr. Richard Culbertson. She's professor and director, health policy and systems management at Louisiana State University School of Public Health, New Orleans. He is a professor of family medicine and of internal medicine at the LSU School of Medicine and adjunct professor of family medicine at Tulane University School of Medicine. Dr. Culbertson has held many leadership roles in many organizations, including Indiana University, Indianapolis, Medical School at the University of Wisconsin-Madison, University of California, San Francisco Medical Group, and Kaiser Permanente Sunset Medical Center, Los Angeles. He has published many articles in many journals and is nationally recognized lecturer and author in the area of healthcare management ethics. His major public service contribution was in the area of healthcare governance. He's the former chairman of the board of directors and board member of the Aurora Health System in Milwaukee, Wisconsin, at the time the largest private employer in the state of Wisconsin. Just quickly, he also, in addition to his academic scholarly pursuits, he's an avid swimmer, having completed the 2009 Alcatraz International Invitational Swim Race from Alcatraz to San Francisco in the non-wetsuit division. And I always enjoy the tidbits, thank you. And then from Australia, we have Dr. Stephen Duckett. Professor Duckett has held senior healthcare leadership positions in Australia and Canada, including as Secretary of what is now the Commonwealth Department of Health and Director of Acute Health in the Victorian Public Service. He's currently Director of the Health Program at Grattan Institute, and I believe he's moving on to some new adventure very soon. And he was Dean of Health Sciences and Pro Vice Chancellor at La Trobe University, and completed a Doctor of Business Administration in Higher Education Management at University of Bath during that time. Professor Duckett is currently chair of the board of Eastern Melbourne Primary Care Network and a member of the board of the Brotherhood of St. Lawrence. And thank you for joining us from Australia. Now, also from Australia, on vacationing but stuck there, Dr. Vivian Lin. Dr. Vivian Lin joined the LKS Faculty of Medicine as Executive Associate Dean in March 2019 in Hong Kong. She's concurrently Professor of Public Health Practice. She has more than 40 years experience in public health and a variety of leading roles in policy and program development, health service planning, research and teaching, and senior administration in complex organizations. Vivian was chair of public health from 2000 to 2013 at La Trobe University in Melbourne, before serving the WHO as director of health systems in the Western Pacific Regional Office from 2013 to 2018. Vivian has also worked at senior executive level in health policy in several Australian jurisdictions. She has also consulted widely for the World Bank, UK Department for International Development, Australian Agency for International Development, World Health Organization, and various Australian governments at state and federal levels. Vivian has served on multiple academic government community boards, and she's also the author of several leading textbooks, and she's currently working on 2 Lancet commissions on gender and global health and on COVID-19. Finally, the moderator today is from our very own USHCA board, and Scott Duckett, originally from Missouri. Scott is currently Vice President of Global Access, Value, and Economics. Sounds like a very big job. Serving as executive and Chief Economic Advisor and Market Access Leader for Intuitive, most well known for the Da Vinci, and that's used all around the world. In this role, Scott leads the strategy, management, and operation of the global GAVE organization. He's trained and applied health economist and strategist with over 20 years experience in healthcare management and leadership roles for life science companies and US honor roll hospitals. He has led health economic strategy, market, patient access operations in more than 30 international markets. Without further ado, let me turn to our panel. One last thing is that if you have questions, please enter in the Q&A, and at the end, we'll have a quick survey. So with that, let me turn it back to the panel, and Scott, lead us through the rest of the program. Thank you.
Thank you, Min. I appreciate it, and appreciate the warm welcome. And everyone, good morning, good afternoon, good evening. To those of you watching around the world, it's a pleasure to have you all. I appreciate you joining us for this really exciting all-star cast and panel discussion, I think, that we have here today. That's being held by the U.S. Heartland China Association on the global pandemic response. And this has been a multiple-part series. This particular series tonight will focus more on what's next on the pathway forward as we move forward collectively around the world on either bearing through the remainder of the pandemic, but also what will happen as we kind of emerge from the pandemic moving forward. So the objectives of the panel discussion is to better understand how the pandemic has challenged healthcare systems around the world. And then based on the local challenges and policies and viewpoints, there have been various responses to the pandemic, and to learn from those responses and to collectively bring those insights forward to where we can share in those and determine how best to proceed forward. Now that we're heading into our 3rd year, there's much that we've learned. I think there's also much questions as far as what are the next steps and what choices do we have in those next steps. And then how do we balance the social and economic dimensions with managing those next steps as we move forward as it relates to the health of the populations, but also the health system's impacts overall. So today I'm joined by the experts in the field of public health, health systems administration, digital innovation, healthcare and policy, and also the intersection between public policy and public health. The panel discussion will be focused a discussion on what we should expect next in the global pandemic response, and the unraveling various local crises and concerns that have further challenged the healthcare systems and the infrastructures that we have today. And then hopefully through this discussion, we will be able to identify some of the silver linings that will help us navigate out of this global crisis into the new normal. So with that, as always, please feel free to submit your questions throughout the panel discussion. I'll be monitoring them as they come in, so I'll try to weave them in as best as I can into the panel discussion. With that being said, I would like to turn it over to our panelists first to get some opening remarks from each of them. In particular, I'd like for each of them to kind of point out 5 major points of reflection to frame the key learnings and insights that each of them can share as far as challenges and opportunities as we look to the next phase of the pandemic and eventually the endemic phase of the pandemic, particularly as we collectively navigate what we might call the new normal as an altered living societal health that we will all become accustomed to as we move forward through the pandemic. So with that, I will turn it over to Vivian and others, and I will call upon you. But feel free to share with what you think are the items that we should be aware of over the next 3 to 6 to 12 months. Also, any key elements that have dramatically shaped the upcoming years of the post-pandemic response. So with that, Vivian, I would like for you to kind of open us up here for a few opening remarks, and again, those 5 points of reflection that you can share with us.
Thank you so much, Scott. Of course, because I sit in the middle of Asia, in Hong Kong, part of Greater China, and having worked in the Western Pacific region since 2013, my starting point is really that when we think about that part of the world, we are talking about Asian exceptionalism. With that, we include Australia and New Zealand, gladly embrace Australia and New Zealand as part of the Asia Pacific region. And really, the approach in most countries has been a zero COVID policy, zero COVID partly waiting for the vaccination to come through. And then in the hope that with vaccination rates going up, one could start to relax. Now, we've seen some divergence, and we've seen still waves in every country, and those waves partly reflect some of the social and economic fabric and the difficulties in these countries. What comes next is this debate about how do we live with the virus, because Omicron has changed the landscape considerably, and it's not necessarily a very easy pivot for many governments when you've been on a zero COVID approach. And we can talk about that further. But if I was trying to then pull out some of the lessons, I would say, firstly, in most of these countries, we see that science matters, that there has been expert advice that's been important. Not all experts agree, but they have been important in the way that the governments have approached it. The second thing I think is that universal health coverage matters. And by universal health coverage, it's not just having health financing that allows for affordable and quality care, but we're also seeing some innovations within that, using telehealth to address some of the access and care gaps, learning that community engagement and outreach really matters and needs to be part of the health system. And then grappling with how do we actually deal with an aging population appropriately. So this is universal health coverage is really such a vital foundation for going forward. The third element, which flow, I think, from the first two, is that we can see that the inequalities in every society has been revealed. So it's that inequality in healthcare access, it's the inequalities in terms of the risks of exposure, and it comes through from insecure employment, migration status, and any number of issues. So the question going forward is, can we actually address these vulnerabilities into the future, so when the next pandemic hits, we're not in the same situation? So that leads me to perhaps the fourth challenge is really recognizing that public health is not just about the health sector, but it really is about a whole of government, whole of society. And we have to think about health in relation to social policy, economic policy. And so governance matters a great deal. And then finally, I think when we think about governance and how governments have handled it, one of the really big challenges is how do you now communicate in a time of uncertainty when the situation is going to unfold and your strategies will change. On the one hand, you have to provide a certain level of comfort for the community and clarity about what the situation is. On the other hand, you also have to prepare people that that advice may change. So I think we are probably going to have to move into a new world in the way that we think about strategic communications with the populations. So I think those are my 5 points. Thanks.
Yeah, Vivian, that's fantastic. Thank you. With that fantastic remarks from Vivian, we'll turn it over to Dr. Duckett. So Stephen, I think you're up next.
Yes, thanks very much, Scott. So thank you very much for this opportunity. What I want to talk about is an immediate problem, and it's an immediate problem caused by the pandemic, but in a very interesting way. And what I'm talking about is the care deficit. That is, during the pandemic, over the last couple of years, we've had a number of hospital admissions which have been deferred. And there are two types of deferral. There's the first type is what I call system deferred. That is, in Australia at least, a number of elective procedures were cancelled to make way for the wave of emergency infectious disease COVID admissions. The second type of deferral, and just as important, is patient deferred. People didn't go to their doctor for that suspicious lump, and they deferred the diagnosis process themselves. Now, obviously, health services were available, but they just felt uncomfortable about going out or whatever. Now, there are a number of consequences of this. Because of this deferral, the treatment actually might be more complex. That is, if it's a patient deferral, the cancer may have grown over that period. If it's a elective procedure, they may have got more pain and their hip or whatever may have degenerated more. So there's not only this backlog of care, but there's this increasing complexity of care that has to be dealt with. That's on the demand side. On the supply side, there is also the problem of the great resignation or the potential that staff will want to leave. They've been under an enormous amount of stress. They've carried this burden of care over the last couple of years. And so they now may be wanting to take a break, or they may have said, enough is enough, I'm going to stop working. So there's this burnout and stress and so on occurring on the supply of staff side at the very same time we've got the demand at a peak level. So what are the lessons that might come from how might we cope with this? Well, over the past couple of years, there's been a mobilisation of all the resources to focus on COVID. That mobilisation has been wonderful and it's helped the health systems around the world cope, but it can't go on forever. So that then leads to the opportunities and the challenges. Basically, what we now know is business as usual will not work. That is, we are going to have to, you just can't say, well, we've got this 20% extra care that we're just going to absorb in the way the health system works. In Australia, at least, the system was stressed before COVID. So that's just not an option. So business as usual is not going to work. So we are going to have to innovate. We're going to have to do things differently. And that's something that I think Molly will pick up in her presentation a bit later. And so best practice and so on will need to spread and we'll need to learn from each other. But in the meantime, so what do we want? The next steps, what we want is different sorts of leadership. We need to have more risk-taking leadership, leadership which is more interested in doing innovation. But secondly, we have to have leadership which doesn't deny the problem. In Australia, at least, we've had a number of leaders who have basically said, yeah, the health system is coping, I don't have to worry about it, or, you know, there's no such thing as a great resignation. What we've got to do is leaders acknowledge the problem is the first thing, and then show compassion to the staff, be with the staff, but also at the same time, change the systems, change their human resource management systems so there's more flexibility. So instead of staff resigning and saying, I can't cope anymore, the staff will feel valued and they will feel that they can take a little bit of time off, but they will be able to come back. And so it is changing all those systems. So it's what I'm talking about is there's the care deficit and we now need to respond to it over the next 6, 12, 18 months. Thanks very much, Scott.
Great. Thanks, Dr. Duckett. That was fantastic. Thank you for that. And with Vivian and Stephen's topics that they've already brought up, I know a number of those comments, we're going to get very much deeper in the panel discussion as we go through the next hour. So with that, Dr. Molly Coyle, she's up next. Molly, can you give us a few open remarks on 5 points of reflection from your perspective? Molly, I think you might be on mute, actually, so.
Sorry, thank you.
Yeah, no worries. We hear you just fine.
All right. Thank you. Well, you know, sitting in the fortress of American exceptionalism, we can only look with a mix of envy and resignation at what was achieved in a lot of countries in the Asia Pacific region in dealing with COVID in comparison to what we've done. And at the same time, we're definitely dealing with even worse problems of the delay of care, the staff burnout, but in a larger sense, the results of our underinvestment in education about science, and the fact that the very question of whether science should be an underpinning and an important determinant in developing public policy is very much open for debate, and a growing part of the population is rejecting science in some very critical ways. And that's tremendously distressing and destabilizing. On top of that, we also have a number of problems in terms of the pre-existing weakened public health structure and a very fragmented, and even though it's called nonprofit, profit-driven private sector that dominates most of the provision of care. So the result is that we have, you could just go through the list in terms of staffing, resistance to vaccines, and a low vaccination rate, the delayed care that Stephen was just talking about, which includes preventive care, inequalities that have been revealed in risk, in diseases occurrence, and in economic resilience and mental health. The result of this has been turmoil and stress and great difficulties. In that kind of environment, I think there are two pieces that matter terribly. One is governance. How do you come to agreement and determine how you will go forward in a number of areas? The second one that is very, very important is how are you going to adopt the appropriate level of flexibility and openness to make use of emerging tools that may be helpful in that setting? And I say this with a great deal of caution and recognition of how difficult this is, not just in the many different countries in Asia Pacific region, within China, and certainly within the United States, that for someone who's spent a great deal of my career working on the evolution of digital and virtual technologies, there are genuinely tools that can help, whether it's communication with the public and with patients, with the staffing, and I'll detail more of that when we get into the panel discussion. But if you don't have the underlying governance, and if you don't have the incentives aligned to improve the care of the population and their resilience in the face of what may be continuing waves of a pandemic, and as we talk among ourselves, the potential of further pandemics within the next 5 years, 10 years, that we are greatly weakened as a society. And I think that the ability to support trust, confidence in governance, and in public health and in science is the core. And the digital tools could be very useful, but it is only in the hands of people who are determined to be open to use them. And they're definitely not the final solution. They're not on their own going to be able to deal with any of this. So I don't want to get put in the box of thinking, oh, just here's a digital tool and you'll be just in great shape. That this is a much more serious issue. I think this is a tremendous social crisis, more than most of us anticipated when we used to do our planning for pandemics 10 years ago or 15 years ago. I don't think any of us really anticipated, at least in the United States, the depth of the chaos that would ensue.
Yeah, Molly, that's a very thoughtful insight, and the convergence of all those things too, I think happening all at once, very, very impactful. So with that, thank you for that. And we're going to switch it over to Dr. Culbertson. Richard, can you give us some 5 points of reflection from your perspective?
Well, thank you. And I just want to acknowledge our audience tonight and wish you all welcome to the Year of the Tiger, wishing you health, happiness, longevity, strength, and peace. And as my talisman for the evening, here he is, wishing you all the blessings of the tiger. Now, having heard my other colleagues, I'm reminded of the statement of that great philosopher, Mike Tyson, who said that famously that everyone has a plan until they get punched in the face. And I think that that is reflective of what has happened in our world in the face of the pandemic, and begs the question then of how will we respond. As Dr. Coyle pointed out, this is presumably not our last pandemic, nor, of course, is it our first pandemic. So I think one of our challenges from the perspective of our supply chain as we look forward is what do we need to do to secure these lessons that we've learned and practices, useful practices that we've developed during COVID-19 to prepare us for future pandemics, and what of those are feasible in the next 1 to 3 years. And I make that statement about temporality because, as it has been commented by others wiser than myself, we are unfortunately not at the beginning of the end. We are at the end of the beginning as we deal with the pandemic globally, I think, in the learned opinion of the scientific community. My background is as a hospital CEO in Los Angeles before I came to academics and ultimately here to New Orleans. And so I tend to view our issues in part those of protection of our workforce, which my colleagues will be dealing with in the main, but also how we can have vital supplies and equipment available to those individuals on the front lines and also to our patients and communities going forward. So I'm trying to assess this evening how can hospitals and their supply chains mitigate future supply shortages while still supporting cost reduction. Because leading up to the pandemic, I can tell you as a hospital administrator, we were probably overly concerned with questions of efficiency and cost reduction to the detriment of resiliency and redundancy, for lack of a better term, in our supply structure. And we ultimately, unfortunately, paid the price, certainly during the onset and first few months of the pandemic. But even today, we still have shortages in various areas emerging, and they affect different providers differentially. Some organizations in our diffuse system in the United States are much better equipped by virtue of volume and aggregated resources to deal with these issues than others. And so I would conclude my portion here with asking the question, how will the COVID-19 pandemic change how hospital supply professionals and suppliers work with clinicians, with finance entities throughout the world of banking, venture capital, private equity, et cetera, and with suppliers going forward. And I very much look forward to our discussion.
Great. Thank you, Dr. Culbertson. That was fantastic. So with that, team, we're going to start to move this into the panel discussion. So I thank you all for your opening remarks. Given the comments and prior questions that actually came in from the participants that are on the line that we received over the last week, and also based on headlines that are populating the major news and journal outlets globally, I'm going to look to 4 to 5 topics over the next 70 minutes for us to venture into and explore together and discuss. And with that, these topics that I feel today are very relevant. Many of them actually you've already brought up, so that's great. And they're also, I think, prudent in the value that we can look to these as being highly dynamic and definitely something that we can all relate to as we move forward, regardless of your country and also regardless of your health system status. So with that, one of the topics that we're going to explore tonight is fit for purpose, which it relates to more of the healthcare workforce, burnout, tiredness, labor shortfalls, and so on. So with that, we're going to explore that topic. The next topic that we're going to talk about, I think Stephen already started to venture into this, is around system and patient deferred care. What's happening within the various countries around the world? What's that going to do as far as impact in the short term and the long term to caring for patient populations, both in intervention and in preventative ways? The next that we're going to venture into is around innovation, particularly as it relates to what we've learned and how digital health technologies will shape the space forward as we move forward. And then the next one we're going to venture into is around supply chain. So what are the short-term and minimal viable product and long-term constraints that our healthcare resources and systems will have to endure as we move forward? Last but not least, hopefully we get to this topic. I think it's a kind of a meaty topic that we can sink our teeth into, is a exploration around same science but different outcomes. So with that being said, just as some of the panelists have pointed to, some of the countries around the world have had very different outcomes, but they've also had very different policies and governance measures put in place that have achieved those different outcomes. So with that, maybe a discussion that's around exploring the sociology around the unraveling pandemic and how that interfaces with medicine, public health, but also those social institutions and communities that have propagated through the pandemic. So with that, I'm going to look to the 4 panelists to contribute to those different topics. Again, with the aspect of what are the problems to solve, what are the key learnings, and then, of course, what are the challenges and opportunities as we move forward and best practices that we can all learn from. So with that, I'm going to actually turn it over to Vivian first, and we're going to talk about the fit for purpose in the workforce and burnout, tiredness, labor shortages. We can go on and on and on about what that is. We've been hearing so much about it in the news recently. Obviously, we've also been enduring it for 2.5+ years. I think that this was a growing crisis that was actually in the mix and in the making well before we actually went into the pandemic. I know we've been talking about it for more than 20 years, frankly, in many countries around the world. But with that, what will the workforce look like as we move forward? Vivian, would love to hear your perspectives on that. What will be the imperatives, the local needs within various markets and countries around this fit for purpose type of mentality? And then what happens with the shortages, burnout, and that impact on acute and preventative care? So Vivian, would love to hear your perspectives on that. And of course, after Vivian's had a moment or two to provide comments, I would love the other panelists to also add commentary.
Thank you, Scott. I think this is really a really important topic. And, it's worth reflecting on the fact that every day we get reports of the number of cases, the number of deaths, maybe the number of vaccines, doses being delivered. But what we have to realize is there's a health worker behind every single one of those numbers. And we shouldn't think about, the people behind all aspects of this effort separate from those abstract numbers. And in the main, we can talk about 2 types of health workers. One is those who are involved in individual care, whether that's in the hospital, in aged care facilities, in primary care, or whether those people are involved in public health. And on the public health side, we've seen insufficient contact tracers, lab capacity, lab people being completely overwhelmed, insufficient health education knowledge. So there's a whole slew of things on the public health side, just as we have heard about the hospitals staffing shortages, the burnout, the long, incredibly long hours, and of course, being at very high risk for infections, because after all, this is where the care happens. Now, I think that two of the gaps that we actually have had, one is that when we actually think about pandemic preparedness plans, which every country has, what do they think about? They tend to focus on, is there enough field epidemiology staff? That's one aspect of public health to go and investigate. But there's an assumption that all outbreaks are short-term, and you just need a short-term surge capacity. So, you can mobilize doctors and nurses from somewhere and just increase the care and you'll be finished. Well, we're seeing a completely different situation, of course, with the pandemic. And so we really have this question of, we already have a global shortage of a health workforce. Where do we actually go? Because it's actually ongoing and it was never part of a pandemic preparedness plan. But we also, when we then look at what countries do on health workforce plans, which usually they don't think about the pandemic. They just think about how many doctors do we train, how many nurses do we train. They don't think about the preventive workforce. They don't think about the public health force. They don't think about the allied health workforce. So I think one of the things that's got to change is actually the way we think about the health workforce, being able to actually work together to address a whole lot of different challenges together. Because if we're going to prevent burnout as sort of the most immediate outcome, we need a prevention and public health workforce that can keep people out of the hospitals. Just as we do need, as Stephen has said, the leadership in the hospitals as well as the health system that can actually, deliver quality health services and manage the staffing situation. But fundamentally, we do also have a quantity problem. And given global shortages, can we actually get there? Now, I think that we do have some examples in the Asia Pacific region where the zero COVID policy actually has meant, for instance, in Wuhan, when we saw this incredible outbreak at the beginning, the Chinese had 10 years of health reforms where they invested hugely in the training of the health workforce. And because they isolated the pandemic at that stage to one city, they actually did a redeployment from across the country. Now, if they actually had let the pandemic happen everywhere, the hospital system, the primary healthcare system would have been stuffed. And this is one reason behind having a zero COVID policy, in the same way that Hong Kong managed it also very tight from a public health workforce in order to not have the hospital system be overwhelmed. In Thailand, on the other hand, what we saw, and we've seen this in other countries, is a real mobilization of community health workers. So instead of thinking about, do we have enough doctors? Do we have nurses? They're looking at a whole variety of people who can be trained fairly quickly, who know the communities, who can do the outreach, who can do the education, who can provide the support in a variety of settings. So I think this starts to get us into a different kind of approach to thinking about the health workforce. So into the future, we need to think about, does every country need the kind of specialist doctors and nurses that we see, say, in US, Australia, and other high-income countries? Or can we make more use of allied health, community health workers, and other types of health workforce? And when you have Pacific Island countries of 10,000 population or 200,000 population, you will never be able to get the kind of specialists that we in larger countries might be accustomed to. So do you need that level of specialization everywhere? Or perhaps you can actually access them globally, regionally, and share better and think about it. Think about the health workforce as a global workforce. And while we're doing that, maybe we can actually rethink the service delivery model and think about, instead of, people crowding into GP practices and hospitals, how do we strengthen the public health competencies, and how do we strengthen multidisciplinary teams? So I think in every country, we do need to think about the context. We need to think about how we move care into the community. We need to think about how we strengthen the prevention, because otherwise we're always going to be continually burdened by hospitals in crisis.
Yeah, that's fantastic remarks, Vivian. I'd like to bring Stephen or Richard or Molly into that. Any other comments that you might have on the fit for purpose and labor shortages and so on?
So without throwing a dampener on all of this, Scott, what Vivian is, the vision that Vivian has painted is one that we've heard many, many, many times before. It's about the model that is imported from the high-income countries to lower middle income countries is obviously not fit for purpose in those countries, and some would argue that it's probably not fit for purpose in our country. My own view, speaking from Australia, is that specialisation helped improve the quality of care up to most of the last century, but because specialisation ended up in atomisation of care and smaller divisions of subspecialties, the increased coordination and the increased complexity started to actually lead to a reduction in quality of care overall, and yet we haven't adapted to that. So I think the issue then becomes is, yes, we've got some observations on the ground of doing things very, very differently during the pandemic because we had to, the innovations that we'll talk about in a minute. Can we actually embed those and show to the population this is actually a better way of doing it? It worked during the pandemic and it should work beyond the pandemic. And so how does the leadership bring the population along to quite a different way of doing it and saying, look, it did work. And we want to actually say that just doing the same thing as you do in the big cities in the United States or Australia is not the right way for us, and it is counterproductive. And so the change management process and the leadership process, I think, is critical to all of this.
Great. Molly, I see that you have your hand up. I'd like for you to get in on that.
Yeah, well, I certainly agree with what Stephen is saying. I think that one of the things that's been very understandable but disappointing is that during COVID, we saw this huge expansion in adoption of telehealth, but it's largely a virtual remote doctor to patient or maybe advanced practitioner to patient communication, and not a lot of the other solutions that can really help. And when you talk about specialists and the guild mentality of the specialists and the silos of the specialists and all, there's actually very good research now that shows that with digital programs, you can have primary care providers who could be physicians, advanced practice nurses, or just nurses trained in primary care, use digital means for getting an electronic consult with a specialist, which is done as an asynchronous email. In other words, you don't have to have the live consult person there, except in certain circumstances. And in that way, you can remove the need for 60 to 70% of all specialty visits that would have been referred to a specialist. So here's a terrific example of something which already existed at the moment COVID hit and had been well researched for 15 years. It's used at Mayo Clinic, all kinds of places, but it's not, I would suspect that only 5 or 10% of the American public has access to it. There's a few places like, Catalonia and other places around the world that are in advance on this. But the guild mentality and the crisis moment of COVID didn't lead to the adoption of that. I think it's quite understandable why not, but it's a shame because there really do exist ways where, if we think about universal health coverage and the approach that makes primary care access central, where you can actually reduce by half or more the need for any kind of direct specialist involvement to deliver good care. And so there are these sets of tools that are kind of sitting on the shelf. And it's not because there isn't good research, it's because of any existing structure has a kind of guild mentality and a whole bunch of rice bowls, and nobody wants their rice bowl broken.
Molly, to build on that, maybe just to come back to a more clarifying question, what do you think has been the major barrier to advancement of widespread telehealth and telemedicine efforts? Has it been really wrapped up within payment systems, or is it where does the payment actually go? What's actually inhibited it from your perspective? The technology's been around for
right.
years.
Yeah. I would say in the past, it's principally been payment, but there also was a very rapid evolution of the technology. Even though we knew technically it could work 10 years ago, the technology wasn't consumer friendly to the extent it really needed to be until maybe a year or two before COVID. And so there's other factors that entered into it. Again, the guild mentality, the sense that the physicians wouldn't accept the idea that patients wanted this, that kind of thing would be a real barrier too. But we're seeing an explosive continued growth of telehealth, the telemedicine in the United States. And the difference is that a lot of the plans, the health plans, which are largely the private insurance companies, that are paid, in the case of Medicare Advantage or Medicaid, with government money as an intermediary to organize care and access to care. And they have realized we can't make mental health available to everybody, make primary care available to everybody without using these virtual tools. And as a result, every single one of the major insurers in the United States within the last year has launched major virtual care products so that people can pay less and sign up for something where your first contact is virtual. And then if you need to see someone physically, you go to that. So, I mean, this is a case where the necessity is the mother of invention, and actually something does move forward. But that's largely unleveraged, meaning it's a practitioner remotely talking to a patient, as opposed to things we're using AI and chatbots or machine learning, et cetera.
Yeah, I think that's a wonderful insight. I think what we're going to do is I'd like to table part of that. Vivian brought up the whole fit for purpose and how do you scale according to population's need at the local level versus more larger countries that have more developed needs for specialists and so on. But how can technology enable specialist distribution either locally, regionally, and globally? So I'd like to table that for the innovation part of the topic. So Dick, did you want to, Dr. Culbertson, would you like to come in on that whole fit for purpose discussion too?
Oh, yeah, I was just reflecting on, tragically, everyone knows that Haiti experienced another earthquake, albeit in more rural areas of the island, but it caused me to reflect back on the earthquake that occurred in the early in the past decade and the devastation that wrought, which was elicited the response of a number of non-governmental agencies, volunteers, et cetera, coming into Haiti for the delivery of care. One of the, tragically, the disease cholera was introduced into Haiti by a peacekeeping force that had set up a camp that basically Public Health 101 resulted in discharge of raw sewage into streams that were used for drinking water, hence cholera, which had no history in Haiti to that time, burst forward as a disease in the population. What was interesting about that particular episode was that the Cuban physicians who were trained in primary care and principles of public health were, on reflection and evaluation, found to be much better equipped to deal with the needs of the population because they were able to rely on basic measures of proper restoration of electrolyte balance, fluid intake, etc., for the individual Haitians, as opposed to the more exotic treatments that we might find in a U.S. hospital at that point. And I think this gets to the issue of trying to find a workforce balance that is in tune with the needs of the population and can move rapidly at the onset of a pandemic condition to hopefully forestall the necessity of more draconian interventions.
Yeah, great.
Can I just butt in there? I mean, I think what we're hearing in that Haiti story is the importance of thinking about public health and prevention right from the start of your training. That is, the Cuban physicians were oriented that way, and that was the way their whole training was oriented. So that is the way they thought in an emergency, or they're able to bring that thinking. And so what needs to be done in the high-income countries is to say, is our current training systems forcing people to go into these specialisation? Is the hidden curriculum one which is really being disadvantaging us to actually get a fit-for-purpose workforce into the future?
Yeah, I think, Stephen, to that point, and I think we'll maybe weave this into the innovation side, is can some of that workforce and distribution of the workforce actually be impacted? I think Molly brought this up well, where through automation of machine learning, artificial intelligence, and so on, that there's solutions to help augment the let's call it the downsizing of specialization that could be achieved through whether it's machine learning and intervention. So with that, any other comments? Because we'd like to move us on to topic number 2, but any other thoughts, Vivian, Molly, Stephen, Richard? Okay. All right, with that, there's been a lot of conversation on system and deferred care. What's going to happen? We've now gone into 2 full years of elective surgeries and elective interventions, people delaying care, people even delaying seeing their primary care physicians, and in hopes that around the corner that the pandemic will start to subside and that they can venture out more with less risk and a lot more safety to their own personal health. That always hasn't happened. We've seen these waves come in and out of the various countries around the world. And with that, now globally, most countries are in a situation of immediate kind of crisis of not only a labor shortage and shortfall, but then the compounded effect of deferred care that's now leading to a more complex, more morbid patient than what we had seen before. And how will that impact the system? So, Stephen, I'd like for you to kick that discussion off. I think you kind of started to touch upon it within your opening remarks. We'd like to dive deeper into that on what you anticipate the various countries around the world on how to react to this and how the health systems will react to this, particularly in the elective surgeries and the elective interventions and so on that have been delayed.
So in my introductory remarks, I talked about basically the problem being on both the supply and the demand side, that on the demand side, there's the care deficit, the deferred care, the system patient deferred care, and simultaneously on the supply side, that the workforce is more stressed and just ready to take a break at exactly the same time we need to be increasing our capacity. I'd like now to link it to some of what we've just heard before about system innovation and AI and all these sorts of technologies. So, for example, let's take hip replacements. Obviously, this has been part of the system deferred care. We've had a whole lot of elective procedures for hip replacements deferred here in this country. this gives us an opportunity to dramatically transform how we think about it. That is, at every point of the care pathway, we can now need to think about, is what we used to do the right thing? So should we have multiple channels into the hip replacement world, or should we have a consolidated single queue, single waiting line, which is more efficient in terms of distribution? Should we actually say, do we really need to make sure that every hip replacement is a needed hip replacement? Have we tried non-interventional, non-surgical treatments through physical therapy, physiotherapy in advance? Have we actually moved in the way that many places in the United States and Europe have moved to same-day hip replacements, mobilising alternative staff, not in the hospital, but in the home, who may be the community health workers, maybe allied health workers of some kind, may not have to be physiotherapists, physical therapists, but maybe lesser trained people, to actually augment the workforce so that we can actually deal with a care deficit. So we need to be looking, and what you do in hip replacements will not be the same as what you do in urology or whatever. So we need to be very carefully thinking through, how do we deal with a care deficit, and what are the options that we've got to actually think differently about, as I said in my earlier remarks, business as usual is not going to work. So we've got to think very, very differently. And how can we mobilize new technologies to do that, and new, not only information technologies, but management technologies and care technologies, home-based, home monitoring, for example, telemonitoring at home, rather than having someone visit, rather than actually monitoring patients in a hospital bed. And all of those sorts of things must be on the agenda now, and we can do it much better now in 2022 than we could have even done 10 years ago in 2012. So that's where my starting comment is.
Yeah, maybe I'll pull another thread on that, and then would love for the panelists to jump in, is how do we think that innovation and technologies will help drive outpatient migration from inpatient units to lower site of care? I think that that's a really interesting area, because so much of the pandemic has forced an influx of patients into the inpatient units. But then the elective surgeries and so on that would have been occupying those beds, obviously they did go into deferment, but could they be otherwise managed through more ambulatory settings and so on? So I think that there's a lot of discussion that needs to take place there. I was actually listening to a recent NPR, I've listened to a lot of NPR episode on now taking pathology, radiology, and so on to the patient's home versus having them come to the acute care facility. And can you actually drive better streamlined care coordination through that sort of model? So I think there will be a lot of care management models that will start to emerge out of this, and obviously technologies that will be looked to help change the site of care and demand and resources. Molly and Vivian, Richard, any other thoughts to Stephen's comments there?
Yeah, perhaps I'll just reflect on some of the issues in the Asia region. I think when it comes to care management, I think eventually hospitals and health services kind of caught on to, you can't defer cancer treatment forever. And you can't, the psychiatric patients are getting worse and worse. And obviously the telehealth solution was the most readily adopted one. And we see that, and that will, I think, absolutely continue into the future. But the preventive services side is actually the other aspect that fell by the wayside. Now, it's one thing to defer your antenatal visits. It's another thing to not do any childhood immunization. And so I think there's also a problem in the mindset of leaders that says we've got this one issue and we only address this one issue and we put all our resources into the one issue, when we actually need to think about a whole range of different populations and different needs. And obviously, there are some countries that are much more constrained in terms of resources than others. But still, we can't actually ignore the diverse needs, because you might address one immediate health problem, you're going to have all kinds of other health problems. So I think somehow the leaders actually need to move into a different headset.
Sure, sure. Actually, Vivian, I just noticed that there is a question in the Q&A from a reporter in China, a China news outlet out of Shanghai, that's actually directed to you with a follow-up question to Dr. Duckett. If you would like, we can continue the panel discussion, or we can answer it live, or you can just answer it through the chat, and we can keep the topic going. So with that, Molly, any other further thoughts that you might have on the deferred care and system deferred care?
No, that was very good comments from Richard, though. Or Stephen, rather, sorry.
Dr. Culbertson, any other further comments on system or deferred care? I think you're on mute.
Sorry, no, I'm in the interest of time. I'm going to let that go because I'll probably circle back to that issue to some degree in my supply chain comments. So
Sure. Yeah.
I'll take a pass.
And I think what we'll also do too is I think the innovation will start to weave between some of these topics here pretty quickly. So with that, I think we're going to move on to the next topic, which is around innovation. And I think we're going to direct this topic immediately to Dr. Coyle. So with that, she started to touch upon this within her opening comments, but what have we learned through the pandemic around the digital health technologies, data exchanges, the disparate impact of EMRs, EHR registry systems that don't necessarily talk to each other and interface with each other. But what have we learned about the power of the ability to take data and to drive it through automation and to also then, of course, put it into more of a solution-oriented approach through telehealth and teleproctoring and so on. Can you give us more insights on where you think the pandemic has catalyzed some of this innovation and where we will start to see more immediate impacts of this innovation starting to touch the different healthcare systems around the world?
Yeah, unfortunately, I mean, it's a very general statement. I don't think that it has done nearly as well as much, the COVID pandemic has done nearly as much to catalyze improvements in the data, the larger data infrastructure, data systems, as we might have hoped. At least in the United States, it revealed the fact that it's enormously fragmented and that the underinvestment in public health meant that the public health systems, even at CDC, were just terribly defrayed and not in condition to deal with the situation. So if it's okay with you, I'm going to interpret this a little bit more broadly, go into that, but then conclude with comments about what I think are the two key paths forward. And one of them is around data, which I think is going to be very important.
Absolutely.
So, working from the sort of, what is the topic that I want to address is what is the potential of digital and virtual technologies, including data, to move us forward and to address some of the problems that COVID has revealed. And I think that the overall two biggest learnings, the first one is that digital, and I'm using digital and virtual because digital in many ways is the data infrastructure, and it's also can be AI and machine learning, and virtual is more talking about how the health workers and the patients experience it because they're able to do it remotely with the support of these technologies. So the first is that it's clear that there are really enormous, substantial improvements in care that are possible with the application of these technologies. At the level of population health, there are more actionable insights and interventions that are possible. They can be brought to the population appropriately to the right people more rapidly. And very importantly, and I'll come back to this later, we also get very clear accountability because unlike most in-person care, there's actual documentation and a clear path and record of what has gone on. So we're able to evaluate the effectiveness much more effectively than we can in in-person care. So when you turn to over-the-shoulder healthcare support, the proctoring or the direct AI support, that also has been shown to directly improve patient access, care coordination, site of care changes, as you were referring to earlier. So the first thing it did was make concrete and real to all the practitioners that this really does provide lower cost, improved access, equal or better quality of care, and a better patient experience as reported by patients, even though they are sacrificing the human factor of being physically in a room with a provider, the convenience, the lower cost, the immediate on-demand nature of most of those interactions is very worthwhile to them, and they're willing to make that adaptation. The second thing I think that's an important insight is that we need to look at this with a lot more mental flexibility from every level of governance down through to the actual practitioners, because as I think I alluded to in the opening comments, most of what we're going to be dealing with for the next decade are hybrid models. There is almost no disease entity that we can think of where there is some part of the population, either for personal preference or personal frailty or lack of digital literacy, are not going to be able to use a virtual or digital first model. And that pretty routinely turns out to be somewhere between 5 to 20% of a population. So if you think about what that means for huge subpopulations by disease entity, by level of care, et cetera, can be helped with these massively less expensive, more accessible forms of care. And we should not be asking the question of, can this virtual technology handle every case? It should be more a question of, can this massively decompress the demand crunch that Stephen was referring to, leading to extended capabilities for lower level professionals and community health workers, and for the patients and their families themselves with appropriate support. That requires strengthening the frontline systems, virtual and physical, so that these handoffs and the integration of care can be done fairly smoothly. I mentioned before how much can be accomplished in terms of specialty care with the e-consult model. And I have a great deal of experience as well with mental health, where we're finding that roughly 70% of people with mild and moderate conditions can be dealt with very well with virtual systems that combine cognitive behavioral therapy, coaching, and a number of other lower professional levels of support for the patients, with a very impressive improvement in their screening results in terms of the level of their disease, their own reports of return to work and activities of daily life, and their mood improvement as well. So this is I believe, going to be the most frequent pattern, is that we will come to a better understanding of which subpopulations are more likely to receive benefit from the virtual or digital kinds of models. Parallel to that, we will have a rapid growth of what you could think of as something like expert hubs. Whatever country you're working in or region you're working in, you only need, in that kind of circumstance, so many specialists of a given type, because they truly are consultants rather than the primary manager of the care. Even in organ transplantation, except for the actual surgery, it's very often a nurse coordinator who is the person who's the best manager of that patient's care in between their acute episodes. So I think that we will see a huge change in the workforce as we finally see the shifting of the burden of care in a cascade down to lower and lower levels, although I don't like the term lower because I think they're very skilled, but in the professional certification requirements, lower and lower levels. And that's accompanied by, and this is another insight that has been very important from COVID, a widespread and growing patient acceptance of this model. but it depends so greatly on having a patient-centered and community-centered design of these interventions. And that's actually been something that has been learned quite well in the US because of the highly competitive environment for these digital innovations. I've been a part of a movement to try to get some of the digital innovations to focus on underserved populations for the equity and social justice reasons. They now realize this is actually a very big market and one that they can address, but that they have to design the products differently. And so I think, I spoke at the very beginning about how important the issue of trust in the health system is for whether you call them patients or consumers or just citizens. But I think that this is a very important insight about what we have to do. Now, I think I'm probably past my time. I had a few observations about best practices and path forward, but I'm very glad to step back if I've run through my time.
Yeah, no, Molly, go ahead. I think we have enough time to get through the remaining topics. Okay. Feel free.
Okay. So in terms of best practices, I think that the single most important one is the shift of our focus. And here I'm talking because all of us on this panel, to some extent, are people who are either have been in the leadership of health systems, whether governmental or private, and in policy for public health and for resource planning for populations. And from that point of view, the focus needs to shift from one that is focused on existing resources and structures and how those should be optimally deployed for the benefit of the population, where you say, well, we've got 20,000 primary care practitioners and we've got 30,000 advanced practice nurses. And so therefore we can afford to do this many people, these many visits or whatever. And instead we should be taking the point of view of what is the job to be done? And you'll recognize that phrase. It's a well understood one. But the job for primary care, for example, is pretty clear from Alma Ata on. I mean, there's been a growing set of details of what needs to be accomplished by primary care. But we're now finding that we can use combinations of virtual and digital technologies in hybrid models of primary care, that where the digital component costs less in US terms than $10 a year for that person's care, that is a subscription that is very, very cheap. Now, the physical part isn't that cheap. But as I was describing earlier, you're offloading a lot of the more mild and moderate conditions into the virtual world. And as a matter of fact, you may know that substance abuse is a terrible problem in the United States, not only opioids, but fentanyl, and I know it is in the Philippines and many other places as well. We now have virtual community mental health centers that accept the people who are addicted into care and provide care for them immediately within a day or two of their being referred, where normally they have to wait 6 months to 18 months to get into a physical community center. And it reduces the total cost of care by thousands of dollars, has very high satisfaction for the patients and a lower relapse rate. So even when it's not mild and moderate, there are large pockets of the patient population that can be addressed effectively. So if our focus becomes, let's look at what is the job to be done, and we force ourselves to entertain other models, then that presents us with a next generation problem. And you asked us to outline challenges. The challenge is that our old means of validating interventions, the randomized control trial that might take 3 years to do, is not very helpful to the leadership of health systems trying to assess how to go forward in these directions. By definition, many of these were only developed 3 years ago. And, very few of them have 3-year randomized controlled trial. And so we are much more in the world of what is field evidence that is considered acceptable. This is beyond the pay grade of any individual person in this. This is a big deal, along with restructuring the IT systems. And those are both big challenges. So let me end with a comment about the IT systems. There is a huge need for information infrastructure, which includes a massive shift to data integration from multiple sources. And there are new technologies that enable this in breathtaking speed. Predictive analytics that return data-generated insights to drive action. And at the same time, enable us to gather outcomes and therefore to generate new knowledge about which interventions are effective. And also welcome field-driven innovations because they can generate these kind of rapid cycle loops. But the final piece to this is that I believe that whether it's the United States or Tanzania, which has done tremendous work in this area, we need a better governance structure for all of this, particularly for the data systems. And that means definition and certification of roles, of budgets, of legislation and regulation. It is a massive undertaking. And we can't wait for that to happen, but we should be engaging in it in parallel. And I think the results in the countries that have undertaken that have been very, very impressive. And anyway, that's the short version.
Well, I think, Molly, that you've really opened up a lot here with your thoughtful comments. Frankly, I think we should probably have another panel just on innovation of technology in healthcare and where that's taking us. But yeah, your insights on the real-world evidence and observational evidence that can be generated through field activities is something that I think all countries can get behind on the power that unleashes to speed that crank of that wheel so much faster and being able to understand through actionable insights where technology and intervention matters and how it's playing out comparatively. So Richard, would you like to also add comments on that innovation topic? And if not, then I think we'll move it on to the next topic.
Well, I just want to commend Dr. Coyle and say that I think that as we move into moving away from the human dimension to our topic of supply chain, that clearly that is another area where analytics and data are key in moving forward from our current, kind of like going to the grocery store and saying, geez, the toilet paper's gone. We've got to do something about it. So you end up running around town or whatever. And hopefully maybe you find it, or maybe you end up using the Sears catalog or whatever the contemporary metaphor for that would be. So I'd just like to commend you on that. And I'll save my remarks for our supply chain discussion.
Great. Well, with that, I think that's where we're at, Richard. So why don't we go into the supply chain, and we're going to have Dr. Culbertson take the lead on this part of the discussion. And of course, the other panelists can jump in. One little twist I would like to enter into this is on the supply chain in particular. Is there anything that we can be doing that as we move post-pandemic in this new environment that could help also ease the constraints around climate change and where that could impact through supply chain efforts and so on. So with that, Richard, can you get into the short-term or minimal viable product or long-term constraints around healthcare resources the shortage around supply chain or the workarounds that are being taken place here in the U.S. and around the world, and also what impacts that you think that that'll have on procedural volumes. As we talked about deferred care, if you don't even have the supply to actually care for it, then what are you going to do and what are you left to do as that impacts the interventional and acute care space moving forward? Can you speak more on that?
Sure. There are a number of extremely important suggestions that you've made, Scott, and how this again, I think that much of what we're doing presently, remember how we got into the supply chain issue 2 years ago, at least as it caught the public's attention. It was over the shortage of personal protective equipment. It was one element. The shortage of tests. Guess what? Mine just arrived in the mail yesterday. I haven't used it as yet, but 2 years later, we're talking about making tests available for the detection of active COVID to the general public. And the third element, of course, was the availability of protective equipment across a spectrum of essential workers in the health professions at that time, which and then in turn led to the question of who is essential. Is it simply individuals engaged in the immediate care process, or is it individuals essential to the support of the care process? Housekeepers, transporters, laboratory personnel, et cetera. And having been a housekeeper at one time, I can certainly vouch for the demands and the exposure that was placed on housekeeping personnel at that particular time. It's been reported that there 43% of healthcare CEOs reported that nurses exited the field during the supply crisis in its early and ongoing manifestation, and that approximately 12% of primary care providers also made such decisions. So our two topics are interrelated on the human dimension here. Furthermore, it's a financial crisis. It's been estimated that $3 billion with a B has been spent on personal protective equipment by U.S. hospitals, and of course, the response to this has been the equivalent of the old stockpiling of inventory as a protective measure to avert future recurrences. It's kind of like that old paradigm of the generals are always preparing to fight the last war. That's the cycle to some extent we find ourselves in. Now, a very dramatic example out of the healthcare environment has been the recently announced decision of the Intel Corporation to invest $20 billion in the construction of a manufacturing facility in Columbus, Ohio, to address the shortage of computer chips that have not only been consequential in the realm of healthcare, but obviously in automotive manufacturing and a whole array of other manufacture of iPhones, a variety of other elements as well. So I think that we've seen, on the one hand, the stockpiling and retaking control of one's supply line in a way that we had not really thought about over the past 20 years. I think that going forward, we probably need to think in terms of what I'd call new market realities. And I'm indebted to the American Hospital Association, with which I've worked in the past for focusing some of these issues domestically, but also internationally going forward. Those realities, I think, that we need to begin thinking about forging new realities with onshore and nearshore suppliers, or to invest in dependable companies, because there was certainly a spate of reported incidents of non-dependable suppliers that fell short of fulfilling their commitments during the early days of the pandemic. That there will be a greater need for what's referred to as bi-directional transparency and a greater sharing of utilization data, getting to Dr. Coyle's point, among healthcare providers, but also manufacturers and distributors, as an argument for augmenting our data capabilities. Thirdly, and this kind of gets at me based on my teaching over the last decade, we taught what we would refer to as lean inventory management strategies to our students, and sort of held them up as a gold standard. I think we should really consider reevaluating across the supply chain continuum a need to better document, to monitor and predict product needs in our daily operations, as well as when, as in the case of the pandemic, product demand surges. It's going to be important to re-examine criteria for sourcing, for connecting and evaluating each product's ability to improve health outcomes, as well as to lower the total cost of care. And finally, to consider whether operational and surge inventories should remain separate. The idea of strategic stockpiles, if you will, of various items, and how much on-hand inventory of PPE and other products should be carried across the supply chain continuum, recognizing that in our diffuse system in the US, that some organizations are much better equipped to address these problems. I refer to large systems which may have the resources and capital to address these systems, and in turn, which may disadvantage small providers, particularly in rural communities and whatnot, that simply don't have access to those resources.
Yeah, sure.
I'm through.
Min, I see your hand is raised there. Yeah, I think you're on mute, Min.
Just really time check. I know Dr. Coyle has to leave. We are going into overtime.
Yeah. Thank you, Min, for that reminder. Yeah, I think Dr. Culbertson, wonderful remarks. With that being said, I know that Dr. Coyle, I think, has left the panel discussion. I think she had a hard stop at the bottom of the hour. I really appreciate everyone's comments, your thoughtful comments, and your expertise. I think it's been a fantastic discussion. With that being said, I actually think that there's two areas that we could look to have another panel discussion webinar, and one of them is around that same topic around the same science but different outcome that we have not been able to get to because of the time constraints here. And then the other one too that we had surfaced during Molly's discussion is around the innovation component. So, Min, that might be another area where we could look to have an ongoing discussion in the short coming months. But again, I thank everyone. Fantastic discussion. I think that the continued sharing of best practices, the challenges, and learning from one another obviously allows us to be more nimble and agile to the issues at hand, but also what we should anticipate in the future too. So, Min, did you have some comments?
Thank you. I was just going to borrow maybe just 1 or 2 minutes, if possible. I know we don't have time to talk about social impact, but again, I remember one of our intern from China asked me the question that don't people in America care about the people who died? What is the cost of life, right? So again, I'm not saying that we got go into a deeper discussion. Would love to hear from Vivian, Stephen, Dick, just very high level quick. What are the social tensions that you think that it's a big thing we need to watch out for? Just a quick comment on the social aspect that we didn't get to talk about.
Yeah, maybe we'll go Vivian, then Stephen, and then Richard in that order.
Yes, I also need to run, but I would say it's brought out the best and the worst in us as human beings, individually and collectively. We have some new habits which are very good, and we need to figure out how to support those going forward. And we need to figure out how to bring into check some of our worst instincts.
Thank you.
Stephen?
Thanks. It's been really, really interesting here in Australia that obviously we've been having daily or weekly reporting of the number of deaths. And many of the politicians and occasionally some of the chief health officers have said, oh, these were people over 75, or these were people with an underlying condition. And that has stimulated a really interesting discussion about, are you saying you don't care about deaths of people over 75? Are you saying you don't care about people dying with an underlying condition? So it's really brought into focus the importance of worrying about everybody and every death, and how every death is a tragedy to a family. And so the language is being challenged about that focus on who is dying.
Thank you.
Richard?
Yes, I'd certainly follow up Dr. Duckett's insightful comment and say that this transcends cost-benefit analysis, and I think gets to the heart of our humanity. And I think that in dealing with the issues that we've touched upon today, that human element has to be first and foremost in our considerations, that this is not purely a realm that lends itself to technocratic solutions.
Great. Thank you so much for the extra time, and have a good rest of your day, Dr. Lin, Dr. Duckett, and thank you, and Dr. Culbertson. Thank you, Scott, for your expert moderation. And hopefully, as you said, we'll do a follow-on at a different time.
Yeah, wonderful. Thank you all so much. I really appreciate the discussion and look forward to seeing you again soon.
Great. Thank you.
Thank you.